That was wonderful, and I want to make a video just like that, but for my
Mm.
hospital too. Um, so actually, it's a perfect setup for what we'll next discuss. As you've heard throughout the last two excellent days of this World Conference, young people with muscular dystrophy are living unprecedentedly fulfilling, strong lives. Young people with Duchenne are living longer than ever. And this makes the need for intentional, dedicated care around sexuality and reproductive health more important than ever. And that's my affirming call to action as a pediatric endocrinologist who cares for the full lifespan of people with muscular dystrophy. But it's also important to acknowledge the dark side of inaction, that we must be motivated to provide sexual health care, education, and resources to avoid the disproportionate rates of sexual abuse, isolation, depression, anxiety, and loneliness in young people with DMD. So, lifelong sexual health actually begins early in childhood when parents and guardians can open age appropriate conversations about body part names, body privacy, and body safety rules. At this stage, children are developing a sense of their body awareness, autonomy, and trust in their caregivers. These foundational discussions help build communication patterns that will support healthy relationships and self advocacy throughout life. During the pubertal years, several key conversations begin to unfold, as Claire mentioned. Adolescents are typically becoming more independent, forming deeper peer relationships and beginning to explore their identity, their autonomy, and their own bodies in a new context. Schools often provide foundational sexual education. Peer relationships take on increasing importance. Physicians will begin to discuss puberty, including when and how pubertal induction may be needed. Families also play a critical role in this process by normalizing these conversations and shaping them in the context of their culture and their values. So, as Dr. Wood mentioned, the puberty evaluation visit is a natural and timely opportunity to talk about a young person's developing identity, including new feelings, goals, and questions around sexuality. These are normal and an expected part of adolescence. For youth with Duchenne, this stage can be especially complex, though. The early teen years often overlap with progressive muscle weakness and increasing physical dependence on caregivers. So while teens are gaining emotional and cognitive maturity, they're also navigating new physical limitations. This contrast calls for greater sensitivity and intentionality from both providers and families during conversations about growing up. Given this context, the endocrinology visit can be a springboard for broader conversations. It's a chance to check in about gender identity before initiating testosterone, clarify what a young person can expect in puberty, including increased sexual thoughts, the difference between reflexogenic and psychogenic erections, and normalizing masturbation as a part of healthy self exploration. We can introduce the topic of fertility early, explaining how testosterone may impact sperm production and exploring any early thoughts around family building a young person may have. Most importantly, the endocrine visit offers a powerful moment to spot any red flags and involve additional specialists early if needed, and if nothing else, affirm each young person's emerging adult identity. As teens transition into adulthood, their cognitive and emotional capacities mature, giving them greater autonomy in healthcare decisions and a deeper interest in intimacy and long term relationships. They should be fully included in standard sexual healthcare conversations, just like any other adolescent or young adult. This includes routine sexually transmitted infection screening, the HPV vaccine, condom counseling, sexual abuse screening, but for older teens with DMD, we must go a step further with additional disability informed care considerations. Ask about sexual activity and offer guidance on positioning and comfort. Discuss cardiovascular safety as it relates to physical intimacy. Explore body image and self esteem. Talk about internet safety and how to disclose a disability in online dating. And continue to provide psychosocial support especially around concerns like isolation, rejection, or navigating relationships. The goal is to ensure every young person feels seen, supported, and respected in their whole identity, including their sexual and relationship lives. In adulthood, the desire for parenthood may emerge as a meaningful goal for some individuals. At this stage, the young person's abstract thinking and future oriented decision making are all well established, making it an ideal time to engage in informed discussions about reproductive health. For those who desire fertility, consultation with a reproductive endocrinologist is key. This specialist can tailor guidance to the individual's personal goals and current treatments, such as whether there's a history of delayed puberty or they're currently taking testosterone replacement. As a pediatric endocrinologist, I don't directly provide fertility treatment, but I do play a key role as a referring provider for my young adult patients with Duchenne who may one day want to become parents. This slide shows a handout I use with my adolescent patients to introduce these topics early, ideally at the time of pubertal induction, and to revisit them during follow up visits. These moments offer a natural opportunity to explain that while testosterone supports the physical changes of puberty, as it was mentioned in the cute cartoon video, it doesn't directly induce sperm production or guarantee fertility. With just a short course of monthly testosterone, some teenagers may experience spontaneous or endogenous puberty, and in those cases, the testosterone can often be stopped. But in others, this triggered puberty effect does not occur, and lifelong testosterone treatment can be needed to support gender presentation goals and skeletal health. In this case, the long term testosterone can actually suppress sperm production, especially when it's used continuously. So I explain to my patients fertility outcomes are uncertain, and sperm production isn't the goal of testosterone treatment, but it actually can happen as a result of it. That's why these visits are a good time to reinforce condom use for all sexual activity and to gently introduce the idea that future parenthood is possible, often with the help of a fertility specialist. Often, my patients are surprised to hear that adults with Duchenne can have healthy children. So it's never too early to begin these respectful, empowering conversations. So, what do I mean when I say that testosterone does not directly induce spermatogenesis or guarantee fertility, but that it can sometimes happen? This diagram shows how the brain signals to the testes to produce both testosterone and sperm. In typical puberty, the hypothalamus releases GnRH, or gonadotropin releasing hormone, which stimulates the pituitary to release luteinizing hormone, LH, and follicle stimulating hormone, FSH. LH acts on the testicular Leydig cells to produce testosterone, while FSH works with testosterone to stimulate the testicular Sertoli cells, the cells responsible for making sperm. But in individuals with Duchenne, who are also on long term glucocorticoids, that entire upstream signal from the brain is suppressed. This is called secondary hypogonadotrophic hypogonadism. The gonad is low, hypogonad, because the gonadotrophins are low, hypogonadotrophic, and all of this is secondary to steroids. So, what happens when we give testosterone replacement therapy? Testosterone therapy replaces the hormone needed for growth, puberty, and bone health, but it bypasses the brain and the pituitary. So that means the pituitary doesn't activate the testis, so there's no LH, no FSH produced. So there's no stimulation of Leydig or Sertoli cells. With no Leydig cell stimulation, there's no internal testosterone production. With no Sertoli cell stimulation, there's no sperm production. That's why testosterone therapy supports appearance related puberty changes like voice deepening, beard growth, phallic enlargement, but it blocks testicular growth and spermatogenesis. Sometimes, as Dr. Wood mentioned, short term monthly testosterone therapy can help jumpstart a child's own puberty. But if natural puberty doesn't happen, lifelong testosterone therapy may be needed. And in that case, if and when a young person has the desire to be a parent, we'll refer to a fertility specialist for more support. If and when a young person has the desire to be a parent, a fertility specialist can offer gonadotropin therapy. This slide shows what happens when a young person is given gonadotropins, either human chorionic gonadotropin or HCG or the hormone FSH. Unlike testosterone therapy, these medicines actually activate the body's natural hormone pathway, stimulating both Leydig cells, which make testosterone, and Sertoli cells, which support sperm production. That's why you see these green check marks across the board. Testosterone, sperm, and all the visible signs of puberty are all supported. And this is the approach we use in adults when fertility is the goal. So you might think to yourself already, why don't we just do the gonadotropins for everyone right from the start? And this is when biology meets more practical considerations. Gonadotropin injections are frequent, often several times a week, much more than what's needed for testosterone replacement. Next, it's expensive. And in the USA, at least, it's not covered by insurance for children. Lastly, most young people actually prefer to defer sperm production until they're developmentally ready for parenthood. So that's typically why the pathway looks more like this. We do testosterone treatment for pubertal induction, followed by long-term testosterone replacement as needed, a transition to gonadotropins if and when fertility is desired, and then a return to maintenance testosterone therapy thereafter. The take-home message is this: hormone therapy can shift over time, from puberty induction to fertility support to long-term maintenance testosterone. We can make an individualized plan based on each patient's goals. So, what do we know about the goals of teens and young adults with Duchenne? Emerging insights are coming from interview studies with young adults living with muscular dystrophy. In a 2024 study published in Muscle and Nerve, doctors Janet Hoskin, Claire Wood, and team interviewed 6 young men with Duchenne aged 24 to 48 through 2 online focus groups. They asked about experiences of sexual health, fertility, and testosterone treatment. 5 key themes emerged, with unanimous agreement that more practical and emotional support is needed for young adults with DMD around sexual health. Fear of rejection in relationships was a common concern, alongside physical barriers that impacted intimacy. All participants felt that testosterone therapy was important, but emphasized the need for integrated psychosocial support. At my own institution in Boston, we reviewed over 1,000 patient years of clinical notes from young people receiving Duchenne care at Boston Children's. We asked, were topics like puberty, sexuality, and fertility ever documented during their visits? And while puberty and genital development were commonly documented, topics like sexuality, erections, and masturbation were rarely noted, and fertility, parenthood, and family planning were documented in 0% of cases. Next, when we looked at when these conversations were occurring in the lives of patients in our care, we felt that many important conversations were waiting much too long to happen. This tells us that even in specialized care settings, critical aspects of sexual and reproductive health care are often overlooked. But it's not without hope. When we looked at the timing of documentation, we saw a clear and dramatic uptick in the reproductive health conversations, especially after launching our multidisciplinary DMD clinic. Since that shift, there's been a rise in documentation around sexuality, gender identity, body image, and more. This shows us that when we create space, structure, and dedicated time to talk about these topics, they do happen. And it's a reminder that multidisciplinary care models help in the delivery of holistic care in DMD. Next, my research team wanted to understand the experiences of young people with DMD in the US beyond our own institution. We conducted a national study reaching out to adults across the US to hear directly from them about their experiences with puberty, sexuality, and reproductive health. This map shows the geographic distribution of the 30 participants. Like Dr. Hoskin and colleagues in the UK, our goal was to elevate the voices that are often left out of these clinical critical conversations and to understand what matters most to young people with DMD. We asked our participants a simple question: have you ever had conversations with your medical providers about sexual health? 60% said no. They've never had a single conversation, and only 1 person had discussed sexual health many times. This shows a major disconnect between what young adults with DMD want to talk about and what's actually happening in the clinic. We also asked participants how much they had thought about the possibility of themselves becoming a parent. Nearly half had thought about it a lot, and another large portion had thought about it at least a little. But when we asked who they talked about parenthood, the most common answer by far was no one. Only 3 participants had ever spoken to a medical provider about fertility. Instead, these conversations were more likely to happen with parents, partners, or friends, if at all. This highlights both the interest and the isolation many adults with DMD feel when thinking about future family building. We also asked participants, if it were up to you, what topics should be discussed with youth who have DMD and at what age. What we saw were thoughtful, developmentally grounded recommendations. Topics like internet safety, puberty, and body image were recommended as early as under age 10. More complex topics like sexuality, dating, and consent clustered around the early to mid-teens. This shows us that young adults with DMD are not only open to these conversations, they have clear opinions about when they should start. So, with all of this in mind, the missed conversations, the expressed needs, and the clear suggestions from young people themselves, we have to ask, what can we do better? As we think about how to improve, it's important to look beyond just hormones and labs, though I love hormones and labs. We need to think about creating space for the psychosocial and emotional dimensions of puberty and sexual health. That can mean checking in on the emotional impact of new sexual thoughts and feelings driven by testosterone. It means opening conversations about body image, self esteem, and what teens are noticing in their peers, especially if they feel left behind. It means offering a safe space to talk about gender identity and not assuming that every patient is on the same path or has the same gender expression goals. And finally, this isn't the work of just one clinician. It might start with the pediatric endocrinologist, but whenever possible, it's imperative to bring in mental health providers, adolescent medicine providers, social work, or primary care to help ensure that sexual health is part of your comprehensive care delivery. We can also start by asking questions of our patients, assessing what education patients are already receiving through school curricula, family conversations, and online resources. When possible, connect patients with external supports. And this shows you here a handout I use in my clinic to connect patients with external supports that are local to my community. So you may have not received formal training on how to talk about sexuality in your medical education, and that's okay, or even as a parent, and that's okay. But what matters now is recognizing that sexuality is a real and important part of life for people living longer with disabilities. It's also a meaningful and addressable part of the transition from childhood to living a full and fulfilling adult life. This is a QR code to a fantastic evidence-informed resource hub from Holland Bloorview in Toronto, Canada, with sentence starters, scripts, and conversation tools designed for clinicians, parents and caregivers, and even patients themselves. And finally, this is also a fantastic resource for families, amaze.org. It offers free, age-appropriate animated videos that help kids and their caregivers understand puberty, relationships, consent, and more. It's available in many languages, so feel free to scan the QR code and share it with families in your practice. Sometimes starting the conversation at home is the most powerful first step. So to wrap up, sexuality and fertility in DMD is not just a hormone decision. It's part of a much broader conversation that includes developmental goals, aspirations for relationships, romance, and parenthood, psychosocial and emotional readiness, and strong support systems for sexual education. This is what holistic sexual healthcare can look like, centered not just on physiology, but on the full humanity of young people living fulfilling lives with DMD. I thank you for your time and openness to this topic, and I just want to thank and recognize the members of the Optimized DMD Consortium, Sex and Fertility Working Group. It's wonderful to work with these individuals and learn from them